Hi, my name is Rob Kamal. I'm an orthopedic hand surgeon at Stanford University, and I'm excited to talk to you about distal radius fractures. Here are my disclosures. So distal radius fractures present in a number of different ways, a number of different patterns, which make them complex to manage. They're complex because the ways in which they present can guide and vary how we approach them surgically, how we approach distal radius fractures technically with various hardware constructs, and how we talk to them about them with patients and how to manage them long term. We'll start with a case. Here's a 60-year-old male who fell from standing. It's AP and lateral of a wrist. Simply, we see a intra-articular distal radius fracture, but what we'll review today is there's more nuance to this in terms of evaluating the pattern and its risk for instability in the future. And we'll review approaches to both surgically reduce this type of fracture as well as how to fix it and prevent complications. So our goals are to analyze high quality images that can inform treatment and what to look for on those images, paying attention to fracture pattern and risks for displacement, how we incorporate patient factors into our treatment plans, how we make sure we identify any other injuries such as DRUJ injuries, and how we place our plate and construct properly to avoid future complications. So first with imaging, on an AP of a distal radius, there's approximately 22 degrees of radial inclination. The dorsal distal radius is typically projected more distally than the volar rim in normal anatomy, somewhere around 3 to 5 millimeters. This relationship can be inverted if the distal radius fracture is angulated in extension, and so you need a lateral view to evaluate that. You can look for intra-articular extension in the radiocarpal joint, as well as intra-articular extension into the sigmoid notch. On the lateral view, the AP distance is around 18 to 20 millimeters. You can evaluate the intra-articular fractures and where they sit on either the volar or dorsal articular surfaces. Look for intercarpal injuries as well as DRUJ instability, such as what is shown in the bottom right here. On a true lateral, the pisiform overlaps the distal scaphoid. In supination, the pisiform is anterior to the distal pole, and in pronation, the pisiform is posterior. Here's an example of a good lateral of the carpus that's called an SPC lateral, where from volar to dorsal, we see the scaphoid tubercle first, then the pisiform, and then the capitate. On an abducted lateral view or the teardrop view, you can see the volar rim of the lunate facet. And that projection of the lunate facet is seen around 10 degrees on a lateral view. That lunate facet projects 70 degrees from the radial shaft and can be used to evaluate for instability of the lunate facet from a distal radius fracture. On other views, both on AP and lateral, you can also evaluate radial height around 12 millimeters, volar tilt typically around 11 degrees, and radial inclination around 22 or 23 degrees. And most studies in the literature use radial shortening of greater than 3 millimeters, dorsal tilt of greater than 10 degrees, or intra-articular displacement or step-off greater than 2 millimeters as indications for surgery. And on the new clinical practice guidelines, these indications continue to be cited. So why do we treat distal radius fractures? If the radius shortens, it increases the load on the ulnar wrist, which can lead to pain. In the normal wrist, the midcarpal motion provides extension. The radiocarpal joint allows for flexion. But when you have dorsal angulation of the distal radius, then the radiocarpal motion increases and midcarpal motion decreases. An example of that type of posture is seen on the right here, where they have adaptive carpal instability from this distal radius malunion that can eventually lead to wrist arthritis. The DRUJ, or the distal radial ulnar joint, can accommodate extension far more easily than it can flexion at the distal radius. And so you lose supination with 20 degrees of volar angulation of a distal radius fracture, as an example. There's other biomechanical effects of distal radius fractures. One is radial shortening. So as the radial column continues to shorten, the volar capsule tightens and prevents ulnar deviation of the wrist. And that prevention of ulnar deviation leads to loss of grip strength. And so here's one study from Chung that analyzed kilogram of grip strength lost for every degree lost of radial inclination. So a good fact to understand and discuss with patients as you're managing them. And we can see why that happens on the right here. You see the capsule attached to the radial column. And as you shorten the radial column and lose radial inclination, you tighten up that capsule and prevent ulnar deviation. We already discussed dorsal angulation and how shifting the contact forces can lead to arthritis of the wrist, and articular step-off, and specifically 2 millimeters of step-off, can lead to at least radiographic arthritis, but may not be clinically relevant. You can have coronal shift of the distal radius, which can lead to instability by affecting the distal oblique bundle of the interosseous membrane. And here's an example of a study whereby cutting the TFCC and shifting coronally by 2 millimeters, the DRUJ became unstable. Intra-articular step-off has been discussed in all articular fractures about the body. Certainly in the wrist, there's some literature to suggest 2 millimeters of step-off leads to radiographic arthritis from the original NERC and Jupiter study. The implications of that on the clinical outcomes are somewhat debatable, with arthritis radiographically not necessarily correlating with any functional outcomes. So what are the guidelines? So the American Academy of Orthopaedic Surgeons and the American Society of Surgery Hand in 2021 convened an expert panel to develop distal radius fracture clinical practice guidelines that I'll review. The first review was on arthroscopic assistance for distal radius fractures. There was moderate evidence that arthroscopic assistance did not aid in the treatment for distal radius fractures. In terms of home exercise programs versus formal physical therapy or hand therapy, there was limited evidence, at least, that home exercise programs work just as well as formal physical therapy or hand therapy. In terms of indications for fixation of fractures in non-geriatric patients, or those typically less than 65 years of age, there's moderate evidence for fixing these fractures in that age group. In the geriatric population, or those often described as older than 65 years, there's strong evidence that operative treatment doesn't improve patient-reported outcome measures any better than non-operative treatment in the long term, and that's typically defined as 6 months to a year. Serial radiographs, there's limited evidence to support serial radiographs after the 2-week X-ray in terms of evaluating for loss of fixation and instability. There's strong evidence that support a number of different techniques for fixation, and that no technique is superior than any other technique in the evidence for fixing distal radius fractures. There's consensus that non-opioid medications can be used to treat pain after distal radius fracture. So for your younger patients, or physiologic younger patients, most commonly less than 65 years of age, operative fixation with post-reduction radial shortening greater than 3 millimeters, dorsal tilt greater than 10 degrees, or intra-articular step-off greater than 2 leads to improved radiographic and patient-reported outcomes. In the older patient or geriatric population, or oftentimes those greater than 65, operative treatment did not lead to improved long-term patient-reported outcomes compared to non-operative treatment. Now, age is commonly used as a proxy for functional demand, and what we'll talk about later is this is a discussion to have with patients in terms of what their functional demand is. Here's an example of an AP lateral oblique of a distal radius fracture treated non-operatively. Here you can see by a number of different parameters, this is a malunion, and yet the patient has good range of motion and excellent proms despite having a radiographic malunion. How do we classify distal radius fractures? There are a number of different ways that have spanned all the way from the 1950s up till recent. And we can see that the classification patterns have slowly advanced as our understanding of distal radius fractures have advanced. So all the way back to 1951, we grouped them by extra-articular displaced, intra-articular displaced, or not displaced. And that's sort of the simplest form. You can see fast forward to 2023, here's another classification system of just radiocarpal fracture dislocations that describe the various types of patterns you can see. Again, an example, here's a Fernandez classification. That's a mechanistic type of classification, so you can try to understand how the injury occurred and how that might guide your treatment. And here's the Kamal and Binger classification on sort of the small fracture fragments involved in a radiocarpal fracture dislocation. So there's a number of different classifications, all of which have low inter-rater reliability. And so what I would suggest is using something a little bit more displacement-based that can guide sort of your treatment principles, opposed to something focused on the mechanism of injury or the parts. And so what I'll describe here is one where you first look at articular surfaces and look if there's articular displacement on or not, including the sigmoid notch, because as we know, that will guide the outcome of the patient. We look at axial displacement and how that can guide sort of how we decide to fix a distal radius fracture. We look at radiocarpal joint displacement, and we look both volarly, dorsally, or if they have ulnocarpal subluxation. And this then guides our treatment and guides sort of how we very specifically create our construct to prevent future displacement. And then we look at the distal radial ulnar joint and evaluate that in terms of preventing continued instability and reducing that displacement. So I'll go through some examples. Here's a example of a 2A. So this is an intra-articular fracture, and there's axial shortening. This is important by principle because we know, one, we have to reduce the articular surface, and two, we have to neutralize the axial shortening, and we have to decide in what order we're going to do that. Do we first reduce the articular surface and then bring that out to length? Or do we create a pedestal at the diaphysis and then work on our articular reduction? Here's an example of radiocarpal joint displacement. So here you have an intra-articular fracture, but you have actual radiocarpal subluxation you see on the lateral. And so we also see another secondary injury. We see a scaphoid fracture. I'm calling this out as important in terms of how you analyze and begin classifying distal radius fractures, because if this were to be missed, if this were to be fixed with a standard volar plate, then it's at risk of dorsal subluxation and failure of your construct in the future. And so we call this out because this is something that requires special attention to the dorsal and lunate facet, for example. When we look at the dorsal lunate facet, we could ask ourselves, well, is there really a critical size that requires fixation, similar to what we've seen in the volar lunate facet? Here's at least one study in cadavers that showed that when you reach at least 40% of the distal lunate facet fracture, you lead to at least 2 millimeters of subluxation of the carpus. So as a general rule, if you see anything close to 40% of the dorsal lunate facet fractured, you should be considering ways in which you're going to focus some attention on capturing that in your fixation construct. Here's another example of a 2B, an intra-articular fracture with radiocarpal instability, but this is volar. This is your classic volar lunate facet fracture that was described by a number of different authors and further specified by Beck in terms of the size of fragment that is at risk for escape with a standard volar plate, somewhere around 15 millimeters. And so here you're again using and paying more focused attention on this fracture pattern in terms of using something fragment specific or a distal type of plate. Here's an example of one of my cases of that volar lunate facet fragment. I've done here a volar arthrotomy, and I'm visualizing now the lunate and the volar lunate facet after osteotomizing some of the callus and then reducing that fracture with a plate that's placed distal enough to capture the volar lunate facet. Here's my fluoroscopic images that show both reduction of the volar lunate facet and then fixation with a distal radius plate. We also can look at distal radial ulnar joint displacement. And so this is something, again, we don't want to miss that goes along with our distal radius fracture, pattern. Here's an AP and oblique of a distal radius. And there's a couple things that we pay attention to. One is the size of the ulnar styloid fragment, and two is the gapping at the DRUJ. And so this has been studied in a number of different ways. Here's one from Phil Blazar's group, where they studied cases and found that the percent of ulnar styloid fractured was associated with greater DRUJ instability, and that any fracture of the ulnar styloid base was at greater risk of DRUJ instability. Here's another study from Omikawa from Japan. Here it's a biomechanical test in addition to clinical cases, and they found that somewhere around 5 millimeters of widening at the DRUJ was associated with distal radial ulnar joint instability. There's a number of ways in which we can also try to diagnose DRUJ instability clinically, both by ballottement and other tests, but they generally have low inter-rater reliability and are not sensitive. So we oftentimes stick with these at least clinical or these radiographic ways of diagnosing DRUJ instability. So some key things to take away: any subluxation of the distal ulna dorsally on the lateral, seeing an ulnar styloid base fracture, you should be concerned, 5 millimeters of DRUJ widening, and a centimeter of initial distal radius shortening in some studies have been associated with DRUJ instability. So are there predictive models for instability after reduction of a distal radius? This has been studied by a number of authors, the original being from LaFontaine with the criteria of 3 or more of the following present: angulation, comminution, intra-articular fracture, ulnar styloid fracture, or age. And these have been corroborated with a number of other studies, most recently from Nick Kasmer's group. There have been some studies suggesting that age is really the predictor of instability. Here's one from Nesbitt, and here's another systematic review showing that age, some dorsal comminution, and perhaps sex may be associated with risks of instability. Ultimately, when we're treating distal radius fractures in these patients in this age group, it's an informed decision-making that requires a discussion with patients. So you discuss the literature, the potential consequences of a malunion, the risks and benefits of surgery, and you can discuss your recommendations. There's been a number of studies done on the fact that older patients do want some role in the decision-making of how to fix their distal radius fractures. There's now the Academy and Hand Society's clinical practice guideline to discuss the risks and benefits of both operative and non-operative in terms of from the long-term outcomes, 6 months to a year being the same. There have been other studies analyzing the various features of treatment, such as being in a cast versus not being in a cast, having anesthesia, having a sort of deformed wrist, and losing grip strength as all features that a patient can use in deciding what the best treatment is for him or her. So you let your patient decide. After discussing that, you talk about actual age versus physiologic age and other parameters. So when you are going to fix, what's the best fixation method? The questions you ask again are looking at if is it extra-articular or intra-articular, is there axial displacement, radiocarpal joint displacement, or DRUJ joint displacement. There's a number of surgical approaches you can use, both from the FCR that's extended or an extended carpal tunnel release. You can go volar ulnar, direct lateral, and dorsal. There's a number of advantages and disadvantages for each of these, and so it really depends on where it is you're going to need to be for both your reduction and to place your hardware. I'll go through just a couple of principles and some extra instruments I always have around. So a Weber clamp, a lamina spreader, any type of micro or mini screws, both headless and headed, threaded K-wires, and a lobster clamp are sort of required for me when I approach these. So we'll go through some examples. The first is coronal malalignment with fracture that extends into the sigmoid notch. Here's an example of that case. Here, 48-year-old male with an intra-articular fracture here that also extends both in the radiocarpal joint as well as into the sigmoid notch. And here's coronal and sagittal CT scans. And this has been studied by Berger and others that show that displacement and step off in this joint can also lead to arthritis at the distal radial ulnar joint. So here we have our fixation construct focusing on both reducing the radiocarpal joint as well as the sigmoid notch at the distal radial ulnar joint. And just some pearls here. Here's my lamina spreader. You can also see here on the x-rays, I have a push-pull screw, and I can use that laminar spreader both to gain length on my construct using a push-pull screw, as well as placing it within the radius and the ulna at the shaft to get my coronal plane alignment. You want to place the plate ulnarly to prevent flexor tendon irritation. There's been a lot of debate in the literature as to risks of tendon irritation and rupture, with evidence both for and against sort of where you're placing your plate. And in general, the conclusions have been that flexor tendon ruptures occur when you have either improper placement of the plate, so typically you're placing it too radial, or you have improper reduction or loss of reduction and extension of the distal radius, which has also been recently shown by Hausman in the journal Hand Surgery. And so what you focus on is when you're placing your plate, they're typically anatomic plates that are made to fit like this. And if you place them too radially, they become too prominent and can cause irritation in the flexor tendon. And so on the right is the example of placing the plate appropriately ulnarly. But here's an example of one of my cases where I place this plate too radially, and it makes it at risk for irritating the flexor tendons. And so that plate should be shifted more ulnarly to cover the intermediate column and the volar lunate facet. You can use extended plates for axially unstable fractures. So again, here's that intra-articular axially unstable pattern. You can either choose to reduce your articular surface first and then build up the diaphysis and the pedestal, or the other way. This is a young person with good bone, so I chose to place lag screws for the diaphysis and build up the pedestal and then reduce the articular surface and place this long volar plate construct. I use Weber clamps almost 90% of the distal radius cases that I do. It helps reduce my dorsal lunate facet. It also helps reduce my volar inclination for my distal radius. So here's an axial unstable fracture pattern that is extra-articular for the most part. And so here you can see me reducing and fixing the diaphysis with lag screws and holding provisionally with K-wires. And then I place my volar plate and I use my Weber clamp to reduce the distal articular surface to my plate and obtain my volar tilt and my final reduction here. If you have dorsal carpal subluxation, similar to when you have volar carpal subluxation, you need some sort of a specific implant to reduce and fix that and hold that fragment rigidly to prevent subluxation. So here's an example. Here's a 19-year-old male, mountain bike accident. You can see this intra-articular distal radius fracture. There's a small volar lunate facet fragment. There's also a dorsal lunate facet fragment with dorsal carpal subluxation. So I need to specifically capture both those fragments with a specific implant that I'm using. So here I've used both a integrated compression screw dorsally to capture the dorsal lunate facet, and I placed a 3.5 millimeter K-wire underneath my volar plate that goes into the volar lunate facet to capture that, as described by Dennison. I also always have threaded K-wires around for my intra-articular fractures. Here's an example of again, a highly comminuted intra-articular distal radius fracture on the AP and lateral. Here's 3D reconstructions. There's an external fixer that's already holding it in place. And so I'm reducing this fracture using standard K-wires and then also placing 0.035 millimeter threaded K-wires, and I cut and place at the edge of the bone and leave in place. And that allows for me to take these very small fragments and hold and reduce them, and they may or may not have been captured by my volar plate or by my dorsal construct as well. Lastly, just a technique to have in your back pocket is the view approach, which is a volar arthrotomy through the volar capsule that you can use for difficult volar approaches for difficult distal radius fractures. This question has been asked by a number of us studying first volar capsule release after stiffness and loss of wrist extension, and then eventually in the safety of doing this in the acute setting and ensuring you don't get radiocarpal instability. And so we've described this technique using it for depressed fragments in the articular surface. If you're dealing with volar carpal subluxation, let's say a chronic volar lunate facet, like I showed before, then you can go through this approach. This approach is a arthrotomy that goes next to the short radiolunate ligaments, but does not touch the short radiolunate ligaments, and can release some of the long radiolunate ligaments off the distal radius to view the articular surface. So here's an example of a distal radius fracture with this depressed fragment at the scaphoid facet. And so here we've used that approach. We've opened up the volar capsule. We're staring at the depressed fragment and the articular step-off that we can then reduce. And here's us reducing it, showing on fluoroscopy how we reduce it with wires, hold it in place with wires, and then place a headless compression screw along with our volar plate to hold it in place. So thank you very much, and I'm hopeful that we're able to review both radiographic evaluation for distal radius fractures, how that can inform how you approach your reduction, fixation, and implants, as well as how you discuss them with patients. So thank you.